Good morning, everyone. So I'll be talking on anterior segment OCT in refractive surgery. So as we know that there are two basic types, that is the time domain and the spectral domain OCT. So the use in laser vision correction is mainly in pre-op as well as post-operative. So I'll be discussing about it. The first thing we'll look for is a central corneal thickness, which is important for screening and surgical planning, and also for the prediction of post-LASIK ectasia. And the more important thing is to look for the stromal bed thickness. So basically it's the safety amount of residual corneal stroma. So this is important before any enhancement procedure and also for the prediction of post-LASIK ectasia. And also ASOCT is used to differentiate from meniscus flap from a planar flap. So the planar flap is biomechanically stable and contributes to the refractive and wavefront outcome of the patients. In case of flap enhancement, for the original flap lift, ASOCT is important for the accurate measurement, and also we can perform a lamella side cut where you can make a smaller and a deeper flap, and for which ASOCT measurement is very important. ASOCT helps you to differentiate from a microstriae and a macrostriae. The microstriae, the irregularities are within the flap, but the macrostriae you can see a full thickness flap fold. This is a ASOCT image showing a flap that is folded onto itself, and this is the post-op imaging of the same. This is another image of the ASOCT showing a hyperreflective dot in the interface, which is suggestive of an interface debris. So most of them are biodegradable and do not induce any inflammation, so hence can be observed. This is a image showing interface haze, showing diffuse lamellar keratitis, which can progress to involve both the center and the periphery. So it has to be detected and treated on time. There is another entity called pressure-induced stromal keratitis, also called as interface fluid syndrome. In the early cases, you can just see an interface haze, which is often misdiagnosed as DLK. But in the severe cases, you can actually see a fluid-filled cleft. So IOP has to be measured, and these cases respond very well to anti-glaucoma medications. This is the pre-op and the post-op picture. Next is the OBL. You can see this dense white hyperreflective dots that is suggestive of an opaque bubble layer. It usually interferes with the eye tracking system. This is more seen in femtolasic flap creation. Also, ASOCT is used to monitor the epithelial healing, basically mainly after C3R and PRK, and aids in the BCL removal at the appropriate time. This is another image showing epithelial pearls and a fibrotic demarcation line suggestive of an epithelial ingrowth. There is another entity called as central toxic keratopathy, which shows a central corneal opacification. The typical feature is an invased dome-shaped homogeneous hyperreflectivity. You can see in the image. The most dreaded complication is a microbial keratitis, which initially is confined to the interface, which can later spread to the flap as well as the underlying stroma. Coming to the epithelial thickness. So we should know that the epithelial cells have a reconstruction behavior after LVC. So what these epithelial cells do is they reshape to adapt the change in the curvature of the cornea. So this is after a hyperopic LVC, and this is a similar epithelial modeling after a myopic LVC. And this is in keratoconus. So for in screening of early keratoconus, the epithelial thickness measurement is very important, and in advanced KC it is obvious. This is intraoperative OCT, which can be used to perform SMILE. It's a real-time imaging, and it is also used to manage complications of SMILE. In case of ICL, preoperative assessment is mainly to measure the anterior chamber depth, and postoperatively it is mainly used to measure the vault. The normal should be between 250 to 750 micron. If it is less than 250, it can lead to anterior polar cataract or the subcapsular cataract, or when the vault is very high, it can lead to narrow angle glaucoma. So the take-home message would be the OCT designs have distinct advantages and the choice depends on each case. So it offers a variety of applications in refractive surgery which needs to be explored and enhanced in the future. Thank you.
There are a lot of other applications also. There's
Yes.
a whole gamut of, you have OCT based tomographers, which was not covered.
Okay.
And that is something which is newer advancement, where you get tomography with the ASOCT, which is more precise than the Schleimflug, because these OCTs have a resolution of 3.8, and you also have swept source OCT. You said only time domain and spectral, but you have swept source, which is actually more important nowadays, even for tomography. Even the IOL master has a swept source for biometry. And of course, the other aspect is in SMILE for interface haze, you can look at it. Of course, you mentioned Bowman's distortions, which is important. But tomography, tomography is very important. The other aspect is OCT can also be used for pupillography, where you measure the pupil size, which is important for refractive surgery. Like the MS39 does pupillography, so you can see the scotopic, mesopic, and photopic pupils when you want to design your ablation or optic zones for refractive surgery. For ICL, you also see lens rise, which is very important. Lens rise is important in determining the size of the ICL. So not only the antechamber depth, but you can also look at the lens rise from the ASOCT. There are a lot of studies now using ASOCT angle-to-angle measurements for sizing of the ICL. So that's also important.